Good morning. Welcome to Medicine Grand Rounds. This is a special Grand Rounds, and I'm really excited to introduce Dr. Jessica Tischendorf. Jess is one of our chief residents, and so this is her debut giving Grand Rounds. She is a native of Wisconsin and a graduate of the University of Wisconsin in kinesiology. She then took her MD with us and graduated AOA in 2013. And of course, we were delighted when she matched with us for internal medicine and has continued on as chief medical resident this year, the Vogelman, Carnes, Endowed chief resident at that. She's already undertaken studies for her Master's of Science in Education Leadership and Policy Analysis here, and will be continuing on next year as a fellow in Dr. Carnes' Veterans Health Administration Advanced Fellowship in Women's Health here at the VA. She's already become active in research, aspiring to a career in infectious diseases. She has already published 6 papers, 3 of recently and just in the last 2 years with Nassia Safdar in the field of infection control. I counted numerous presentations, but 7 regional and national presentations since 2009, where she started out with the American College of Sports Medicine at their annual meeting in Seattle. She's spoken to Wisconsin ACP twice. She's spoken at the Society for Healthcare Epidemiology of America at their spring meeting in St. Louis in 2017, as well as the Central Group on Educational Affairs regional meeting in Chicago. And most recently, she was on an abstract that was presented at the Academic Internal Medicine Week here in Baltimore just a month or 2 ago, and received the National Clerkship Directors of Internal Medicine Innovations in Medicine Education Award. Jess has been an active and volunteer and a good citizen overall in the community and academics. She's served as a clinical preceptor for the 3rd year internal medicine clerkship. She's been a small group leader for Foundations in Medicine, and currently is on the resident committee for the LCME reaccreditation group. In terms of other professional activities, in 2010, she served as a representative for the Alcohol Task Force in the University of Wisconsin and a committee chair for the Body Donor Memorial Ceremony for her medical school class. She's been a member of the Advocacy and Intervention for Medical Students Committee and a representative for UW Hospital and Clinics to the Doctor's Dilemma Jeopardy. And finally, she's actually already an ad hoc reviewer for the Journal of Women's Health. Now, along the way, she's received a number of awards. I'm almost done, Jess. Don't worry. Yeah, you're liking this, huh? A number of awards, including the John Kimberly Curtis Award from the Department of Medicine during her internship year, and the Glasgow Rubin Certificate of Commendation for Academic Achievement from the American Medical Women's Association. On top of all of that, I've really enjoyed working with Jessica as we've put together what I think has been a wonderful Grand Round series this year, and keeping up with the high standards of that. It's my pleasure to introduce Dr. Tischendorf as she presents Teaching How to Teach, Developing the Next Generation of Medical Educators. Welcome.
Thank you, Dr. Page, for that kind introduction, and thanks to all of you for joining me here this morning. As Dr. Page said, I'll be speaking with you today about developing the next generation of medical educators, our residents, who I appreciate sitting right in the front. But first, I want to take you through a thought exercise. I'd like y'all to close your eyes, and I want you to envision the best teacher you've had. Maybe that was a teacher in elementary school, perhaps a high school science teacher. Maybe that was a college professor who taught the material in a particularly impactful way. A preceptor early in your 3rd year of medical school. Or maybe that first attending on the wards as an intern. With that individual in mind, I'd like you to reflect on the behaviors, the traits, the characteristics that made that teacher so impactful. You can open your eyes. Maybe some of those characteristics are depicted here. The literature on effective clinical teaching tells us the best teachers are competent, they have a strong fund of medical knowledge, they're encouraging, enthusiastic, stimulating. They're strong role models and create a supportive learning environment. They have strong communication skills. Their teaching is practical and organized, and they have strong feedback skills. I asked our residents to reflect on their best clinical teacher, what made them so great. And this is what they said. They dedicated teaching time in short segments at times which didn't interfere with us getting our work done. They put in time to prepare so their teaching was purposeful and directed. They had an ability to guide me through a topic by asking questions that walked me through a difficult subject step by step. They created an environment conducive to learning and ignited a curiosity for learning. They asked questions in order to gauge depth of understanding. They provided clear, actionable steps and provided positive feedback. Noting the comments our residents made, what we just learned from the literature on effective clinical teaching, and the reflections that you had on your best teacher, I'd like to pose a question. How many of these qualities did you have when you began internship? I'll spend the rest of my time here today convincing you our residents can develop these qualities with strong mentorship and intentional programming. These are the objectives we'll achieve today. You'll appreciate the vital role our residents play in educating students and peers. You'll understand resident perceptions of their role as teachers. You'll become familiar with a variety of programs to develop teaching skills in residents and identify a strategy you can incorporate in your practice to promote the teaching skills of our residents. And this is how we'll get there. First, we'll review expectations for teaching amongst our residents and time spent teaching. We'll talk about student and resident benefits of teaching, the effectiveness of resident teaching, programs to develop teaching skills in our residents, and then again, strategies you can implement to support the teaching skill development of residents. The ACGME, the LCME, and the ABIM all highlight the importance of residents as teachers of patients, families, students, co-residents, and the interprofessional healthcare team. Faculty similarly have high expectations of resident teachers. This was a survey of nearly 100 clinician-educators. Nearly all believed that teaching was a primary responsibility of residents, and over 3/4 believed teaching ability should be a part of clinical evaluations of residents, and that teaching should be regarded as an integral part of residency. What about our faculty? Michelle Kipp was kind enough to compile evaluation data of our PG 2 and 3 residents for the past academic year. Our faculty encourage our senior residents to continue teaching, shift attention to more of a teaching role, develop a strategy to teach more, increase teaching when possible, and perhaps the most inspirational, become a fabulous teacher. So with these high expectations for residents teaching, we owe it to them to develop these skills. Do residents rise to the occasion? How much are they actually teaching? This was the earliest estimate I could find in the literature. In 1970, Robert Brown published a time motion analysis of an internal medicine resident's work week, and he estimated that 25% of a senior resident's work week is spent teaching, supervising, or evaluating junior house staff or students. The post-duty hour era, technical difficulty. I think we got it. Thanks, Glenn. The post-duty hour era suggests this estimate has decreased. So back it up a little bit. Here we go. This is a systematic review looking at time motion studies before the institution of the first iteration of the duty hour restrictions. As you can see, before duty hours were initially implemented, residents were spending 18% of their work week in teaching and learning activities. After the first iteration of the duty hours, that dropped to below 12%. Two more sobering estimates were published in the Journal of Graduate Medical Education in 2011 and 2012, which estimated that interns only spend about 1% of their day teaching. Now, I thought this was a gross underestimate based on my experience in residency and what I observe of our residents, so I asked them. 33 residents were kind enough to respond to a survey I prepared for this talk the same week as the ACGME surveys, so I was actually pretty pleased with that response rate. I asked our residents to estimate in a given work week how much of their time is spent teaching medical students. The majority estimated it at about 5 or 10%. On average, 10% of a resident's work week is spent teaching students. Not depicted here, but I asked them to estimate what additional time was spent in direct supervision activities. That was about another 10%. I then asked our PG2-3 residents on a typical inpatient rotation, what percent of your time is in teaching and direct supervision of junior house staff? And more variability here, but on average, senior residents estimate about 40% of their workday is spent teaching or supervising. So we have significant expectations of our residents as teachers, both from oversight bodies and amongst our faculty, and they spend a lot of time teaching. But what benefits do our students receive from resident teaching? That's what we'll talk about next. So these two studies, one from the 1960s and one from the, this isn't showing up in entirety, but I'll explain to you, one from the 1960s and one from 1992, asked medical students the same question. Of medical students completing their third-year internal medicine clerkship, what percent of knowledge gained was from various sources? So both in the 1966 study and this study was from 1992, residents report about 40% of the knowledge they gained on their clerkship was a result of their own initiative. It was the work they put in on their own time. Faculty contributed up to 25%, but the remainder, 40% of the knowledge medical students gain on their clerkship is a direct result of resident or intern teaching. We know that students who work with the best teachers tend to do better on standardized exams, and those that work with highly rated teachers are more likely to choose internal medicine as a career. Those working with the worst or the lowest rated teachers are less likely. This influence is not restricted to faculty alone. This was a study that asked 150 medical students as they were awaiting their match result, what group of individuals was most influential in your career decision and in your education? As you can see, attending staff, depicted in the medium gray here, were more influential than residents in the career decisions of students. When asked who was more influential in their education, residents depicted in the dark gray here were at least, if not slightly more influential than faculty in the education of students. This study from the surgical literature attempted to identify independent predictors of clerkship satisfaction amongst third-year medical students. As you can see, 3 of these predictors map directly to resident contribution. Residents respecting students, providing teaching experiences, and serving as role models. Faculty were certainly important, particularly faculty serving as role models, respecting students, and stimulating outside reading. But it appeared the teaching experiences provided by residents predicted medical student clerkship satisfaction more than those provided by attendings. So why might this be? Why are residents so influential in the teaching of medical students, in the education of medical students? I'd like to introduce 3 concepts that I think help us to understand that. Near-peer teaching, psychological size of distance, and mastery. But first, what is a near-peer? Not everyone's heard that term. A near-peer is simply someone who's gone through a challenge facing an individual recently. They're situated between novice and expert on the development of mastery. With our construct today, novice being student, near-peer being resident, and attending being expert. Many students believe near-peer teaching is as effective as teaching by faculty, and note that near-peers tend to be more practical than senior faculty in their teaching. Sessions delivered by near-peers are often enjoyed more and rated as more relevant and teachers more approachable. 2 studies in the anatomical sciences literature tried to identify if distance along the near-peer spectrum mattered. So they assigned preclinical medical students to anatomy lab sessions taught by third-year students, fourth-year students, or junior house staff. And interestingly, the anatomy lab sessions taught by third-year and fourth-year students were rated more highly than those taught by house staff, suggesting that distance on the near-peer spectrum, in fact, does matter a great deal. 2 qualitative studies attempted to explain this relationship more in depth. Participants in these studies noted that near-peer teachers take more time to explain concepts, they create a safe environment to raise questions, and that teaching provided by near-peers is less pressurized and more in touch with the student learning level. 2 additional concepts I'd like to introduce are psychological size and psychological distance. Psychological size is simply the perceived difference in status. For example, Dr. Vogelman's psychological size is certainly larger than mine. That would allow some interns to feel more comfortable coming to me before him with their concerns. Psychological distance is the degree of emotional connectedness in a relationship. Smaller psychological distance contributes to positive learning experiences in medicine, and smaller psychological size leads to a less pressurized teaching environment, which some students respond favorably to. The final concept I'd like to introduce to explain why residents are so influential in the education of students is mastery. This construct of mastery was first proposed by Sprague and Stewart in 2000. Learners begin on the far left of this spectrum, unconscious incompetence. They have no idea what they don't know. Learners then progress to conscious incompetence. They're beginning to realize all it is they don't know. Think about this as the third-year medical student on their first ward rotation. They're overwhelmed by all the medicine they have yet to learn. Learners then progress to a state of conscious competence where they've achieved some level of mastery, but it takes significant cognitive effort. I think our residents lie here. Very competent, but certainly need to work harder at their skills and knowledge than experts, which lie at the far right of the spectrum, unconscious competence. Experts have developed some degree of automaticity or shortcuts in their knowledge construct. They organize and interface with their knowledge differently than novices, which in some cases can make it difficult to then transfer that knowledge to novices. Perhaps owing to proximity on the spectrum of mastery, residents are better able to deconstruct material, deconstruct component tasks, to deliver that information to students more effectively. And the greater degree of cognitive and social congruence between resident and student can enhance student achievement. So we know residents are influential in the education and career decisions of medical students, and we consider near-peer teaching, psychological size and distance, and the development of mastery as reasons why. Are residents excited about their role as teachers? What do residents perceive about this role? The literature shows that residents acknowledge teaching as one of their primary responsibilities, and the majority enjoy teaching. I asked that same group of 33 residents to what extent they enjoyed teaching students or junior house staff. All enjoyed it at least somewhat, with 2/3 asserting they enjoy teaching very much. I followed up with, what is it about teaching that you enjoy? Knowing that I've made a difference and helped the student progress along in their education. The connection, when the students' eyes light up and you can tell they're genuinely interested. Learning about my own gaps in knowledge. Challenging myself. Reinforcing my own knowledge and skills. Taking something that I previously struggled with, identifying how to make it easier, and feeling like the next group might understand it better than I did. Learning more about the topic I'm teaching. Teaching allows me to master the material and respond to questions that learners may have that will further expand my knowledge base by forcing me to look up new things. One resident was particularly insightful, and I'd like to share some excerpts from comments they made. I enjoy the opportunity to have a small role in the development of future physicians. It's rewarding to watch students or interns begin to make connections. Spending time with learners continues to push me to read and learn more. I hope to become stronger by expanding my medical knowledge, but also by improving my communication skills, because I'm a teacher to my patients too. Many of the benefits our residents assert are consistent with those found in the literature. Preparing a teaching session on a topic enhances knowledge acquisition compared to more passive learning techniques such as listening to a lecture. Residents learn a great deal through teaching and find it useful in board preparation, and teaching positively influences medical residents' self-perception of professional competence. Two studies, one relatively recently, published in 2015, examined the correlation of teaching abilities and in-training exam scores and found a weak but positive correlation between the two. I'm certainly not proposing that as causal, but it is an interesting observation. From the standpoint of a department, residents highly engaged in teaching in these two studies in a clinician-educator track are more likely to stay on in academic posts and have higher rates of scholarship. So developing the skills of residents as teachers is not just important to the students and residents, but for the health of a department. Fulfilled residents are more likely to stay on as faculty, who in turn then influence the careers and education of more students and residents down the line. So with all this emphasis placed on residents as teachers, are they any good at it? What data do we have to show that they're effective educators? That's where we'll focus our time next. But first I wanted to get at preparedness. So I asked our residents, to what extent did they feel prepared for their teaching role when they began internship? For one lucky individual, they felt very prepared. But about 60% felt they were not at all prepared or received very little preparation for their teaching role prior to internship. Despite this perceived lack of preparation, residents have been demonstrated to be effective teachers in a variety of settings. In two studies from the surgical literature, the teaching abilities of residents were actually rated more highly than those of faculty. In the emergency medicine literature, residents are equally effective facilitators and debriefers of simulated teaching. And with teaching skill development, residents can be as effective as faculty in facilitating problem-based learning sessions. This certainly has implications as medical schools continue to focus on that learning for their students. I'd like to present some local data, but first I need to describe to you the internship preparation course. This is a 2-week course for graduating medical students at UW-SMPH that attempts to ease the transition from student to intern. In the first 2 years of the course, 2015 and 2016, our residents were highly involved. They taught 60% of the didactic sessions and were involved in nearly all of the simulated sessions. I'll make a note, for those of you involved in the medical school, this is just a harsh reality that we've experienced in the last 2 years, or last 2 weeks. Enrollment in the first year was 8 students. It was then 15 last year, and now as a graduation requirement, 150 students went through this curriculum this year, and our residents remained highly involved in the success of that endeavor. In the first 2 years of the curriculum, we gathered student self-report of preparedness to address topics taught in the course. As you can see, no matter if it was the resident teaching session or a faculty teaching session, the course did its job. Students felt more prepared to address topics taught in the course after. There was no difference in student self-report of preparedness between sessions taught by residents and faculty, and I would argue perhaps greater gains in reports of preparedness for those topics taught by residents compared to faculty. We asked students, overall, how would you rate this session? 2015 data on top, 2016 below, residents in the red, faculty in the orange. As you can see in both years, those sessions taught by residents were evaluated at least as favorably as those taught by faculty. So I present this data to demonstrate that locally our residents are as effective as our attending physicians in teaching in the intern prep course. What about on the wards? What do our students say about resident teaching on the wards? Chelsea Anderson was kind enough to compile student evaluation data on our PG 2 and 3 residents for the past academic year. And this is what they say. I think the best thing Dr. X did was make time for teaching. She provided students very helpful feedback on presentations, assessments, plans, and notes. I was especially appreciative X took time to give mini lectures and reviews about relevant topics. So while overall viewed very favorably, the students also identify some opportunities for skill development. More bedside teaching. Give more feedback. As he moves forward as an attending, take time to do mini lectures. Try to incorporate more actionable feedback throughout the rotation. So we know residents can be effective teachers in a variety of settings, and their teaching is viewed favorably, but students do identify some opportunities for skill development. And that's where the proliferation of resident-as-teacher programs can provide insight into how we go about developing these teaching skills. I asked our residents if they would be interested in a formal teaching skill development program. 36% said, yeah, I'm already participating in one of these programs. An additional 43% said, I'm not participating, but I would be interested in some formal teaching skill development. So that's nearly 80% of our residents who are either participating in one of these programs or would be interested. This material is a little bit dated now, 15 years old, but I think still the most comprehensive review we have of the prevalence of these resident-as-teacher programs across graduate medical education. When published in 2001, Med-Peds Programs and Pediatrics programs were really at the forefront of these resident-as-teacher curricula. In internal medicine, we sat at 65%, which still far outpaced the more procedurally based specialties, with surgery programs sitting at 31% having a resident-as-teacher program. Fortunately, we have some updated prevalence data. Now 95% of family medicine programs, 87% of pediatrics programs, and 60% of emergency medicine programs offer teaching skill development. I don't have a formal estimate of the prevalence in internal medicine currently, but anecdotally, these programs seem to be increasing. When faculty clinician educators are asked what skills are important to develop in aspiring clinician educators, most assert communication skills, clinical teaching, assessment, curriculum development, program evaluation, and education leadership are very important to develop in future clinician educators. I would argue that perhaps with the exception of communication skills and clinical teaching, these are not skills our residents are going to pick up on the fly, and if we want to achieve these outcomes, it requires intentional programming. When medical students are asked what skills are important to develop in their resident educators, they cite giving feedback, teaching problem solving, leading discussions and managing a ward team, delivering an effective lecture, improving teaching rounds, and bedside teaching. In 2016, the Association of Medical Educators in Europe released a guideline to the development of these resident-as-teacher programs. The most basic resident-as-teacher programs should teach specific teaching skills: how to teach a procedure, how to teach the bedside, role modeling, and working on interprofessional teams. We know that our residents don't just teach students and co-residents, but the healthcare team at large. More advanced programs should incorporate learning theory and learning styles, the principles of adult learning, the best evidence in medical education, and some component of reflective practice. And programs aspire to incorporating educational leadership and scholarship, mentorship activities, and engaging in teaching the teacher activities. So how is this operationalized? How do we actually teach these skills to our residents? This was a review of 39 published Resident-as-Teacher curricula published in the Journal of Graduate Medical Education in 2014. This was across graduate medical education, but for reference, about a third of these programs were in internal medicine. Most were workshop-based, 62%. About a quarter were a series of lectures. 20% included a predominant coaching or feedback mechanism, and then a minority were teaching rotations. And again, this is just published curricula. Most interventions were brief, on the order of hours to short days. Another review published in 2004 looked at how these resident educators are assessed, and the mechanisms of assessment are varied. Most common is self-assessment, but videotape review, learner evaluation, and objective structured teaching exams, or OSTEs, are also common. Of the 14 curricula that were reviewed, 13 demonstrated quantitative benefit, suggesting that with very little time investment, we can achieve these positive outcomes for our resident educators. I'd like to hold up 3 exemplars of these curricula for you today. One, a workshop or lecture-based program, a teaching elective, and a clinician-educator track. First, the BEST curriculum. And I have BEST in quotations there because it's an acronym bringing education and service together, but it's also the best studied and most widely disseminated curriculum of its type. It's a 13-hour, 6-month curriculum for generalist residents, family medicine, pediatrics, internal medicine, that was developed at UC Irvine. It kicks off with a 3-hour workshop and then 10 one-hour noon conferences. The modules covered include identifying the teachable moment, 5-step microskills for teaching, leadership and role modeling, orienting learners, giving feedback, teaching at the bedside, teaching procedures, teaching inpatient, teaching charting, and giving lectures. The authors conducted a randomized controlled trial of 60 family medicine, internal medicine, and pediatrics residents, and as assessed by OSTE, the residents participating in the curriculum had significant gains in all the domains taught. The authors then conducted follow-up interviews of residents participating in the trial 1 year later and showed that the residents that participated in the curriculum demonstrated greater enthusiasm for teaching, learner-centered approaches, a greater understanding of teaching principles and skills, and more had plans to continue teaching after residency. Teaching electives, while less common, can be very robust teaching experiences for residents. One I'd like to highlight is a 2-month teaching elective for senior psychiatry residents at Mount Sinai. During this 2-month elective, residents spend 60% of their time in teaching activities and the remainder in outpatient medicine and didactics. And throughout, they have weekly mentorship meetings with the program director. This is a visual representation of all the teaching opportunities residents are afforded in this elective. They conduct case conference 3 to 4 times weekly, which consists of them actually bringing the inpatient teams to the bedside. They attend select inpatient morning rounds and provide consultative services to internal medicine residents. For third-year students, they prepare 2 or 3 formal lectures per rotation and administer and grade the final oral clerkship exam. For fourth-year students, they serve as a mentor to those applying to psychiatry residency, and then also invite them to a journal club that they also conduct for the PG2 residents. For the interns, the teaching resident meets with each of the interns on the inpatient psychiatry service once weekly to provide direct observation, prepared teaching, and also just to discuss how the transition to internship is going. And then for the PG2 residents, in addition to the journal club I mentioned, they facilitate fresh case discussion on a weekly basis. Clinician-educator pathway I'd like to highlight for you comes from the Beth Israel Deaconess Medical Center, internal medicine residency. All PG1s in good standing are invited to apply, and 6 are accepted each year. And this is a schematic of the curriculum for that pathway. There are some longitudinal opportunities. In their intern year, residents identify their scholarly project that's then executed throughout the remainder of their residency. They participate in observation of teaching masters and peer observation, and then they have several teaching opportunities embedded throughout the curriculum. The didactic portion begins with workshops on the basics of medical education and biomedical research, and then more brief sessions conducted throughout the remainder of their residency focus on adult learning, assessment, feedback, ambulatory teaching, more advanced topics for the PG3s, negotiation skills, scholarly writing, learner remediation. Residents participating in this track report a high level of satisfaction and significant gains in confidence in core medical educator skills across time compared to their self-assessment in their PG1 year, but also compared to their co-third year residents who did not participate in the curriculum. These are all the outcomes that residents demonstrate gains in confidence. And they vary from designing curricula, providing feedback, teaching in a variety of settings, role modeling and promoting critical thinking skills, applying adult learning principles, creating a safe learning environment, and determining the needs of learners. What are we doing here? How are we developing our residents as educators? I'd like to share two opportunities with you this morning: the Education Academy for Clinical House Staff, or TEACH pathway, and the Resident-as-Educator curriculum embedded in the internship preparation course. So the TEACH pathway was co-developed by Drs. Amy Zielinski, Jeremy Smith, and Joan Addington White, along with a committee of residents. Continues to be led by Dr. Zielinski. Residents apply in their PG1 year, and 5 are accepted each year. And upon acceptance, they're paired with a faculty educator mentor. And that faculty mentor continues to meet with that resident through the remainder of their residency. The didactics in TEACH pathway include workshops on the basics of teaching in the clinical environment and education research. Then more brief classes on learning theory, active learning, and assessment and evaluation. Throughout their participation in the curriculum, residents develop their teaching philosophy. They conduct medical education journal club. They perform education literature reviews. Their faculty mentor performs direct observation of their teaching in at least 3 venues, and they participate in peer observation activities. And as a capstone, residents can develop a curriculum to be submitted to Med-Ed portal, or they conduct an education research project. Near and dear to my heart is the Resident-as-Educator curriculum that's embedded within the internship preparation course. I co-developed this curriculum with Dr. Sarah Johnson in 2014, and it's designed to align with the teaching activities of our residents in the internship preparation course. And as a reminder, for those of you not familiar with this course, this is that 2-week elective for graduating medical students in which our residents teach a significant amount of the didactic and simulated sessions. Our curricular activities are mapped to 2 overarching goals. Residents prepare and deliver a teaching session in the internship preparation course, and we also emphasize the importance of giving and receiving feedback effectively. To that end, we have our residents deconstruct the components of developing a teaching session. They develop learning objectives. They consciously select the most appropriate teaching method. Is this content suited for a lecture-based session? Is this suited for a small group session? They outline their content and delivery methods explicitly and then actually execute delivering that session in the intern prep course. We also have them participate in peer and faculty feedback activities. This is a schematic of our curriculum, and I think what's particularly innovative is very little of it is actually face-to-face. We have the residents meet with us actually for 2 one-hour sessions in which we focus on the basics of classroom teaching and feedback, but the remainder is designed to be done asynchronously. Between the sessions, residents are drafting their objectives and outline, which they receive feedback on. They participate in peer observation, and then ahead of their teaching session, they make explicit the particular goals or challenges they've had and what they want us to directly observe for in the intern prep course. Dr. Johnson performs direct observation and feedback of each of these teaching sessions, and that feedback combined with student feedback is then delivered to the resident and incorporated into goal setting as they move forward as educators. Because we want to continue to develop our resident educators, we've designed a scaffolded curriculum to challenge them as they continue to participate in consecutive years. In the first year, we really focus on the basics of classroom teaching and giving and receiving feedback effectively. In the second year, we challenge them with more advanced classroom management techniques and curriculum evaluation practices. And then in the third year, they take on a mentorship role. They're paired with a first-year educator, and they also participate in individual goal setting. For example, many residents are using this as a natural lab for their Teach Pathway capstone. The pedagogical basis of our curriculum is really fourfold. By aligning our didactics directly with the development of a teaching session, situating it within and contextualizing that learning, we believe we're making a greater impact. By deconstructing the component tasks of developing an effective teaching session, we're giving residents an appreciation of all that goes into developing a 60 or 90-minute lecture, but also making that task seem less overwhelming. Peer feedback, similar to near-peer teaching, is viewed favorably, and it's valuable to the learning of not just the individual getting the feedback, but the individual providing the feedback. And then with the scaffolded nature of the curriculum, we're really trying to challenge residents within their zone of proximal development. For those of you not familiar with this concept of the zone of proximal development, it's depicted here. For residents with a high level of competence relative to the level of challenge, they're going to be bored. For learners with a high level of challenge relative to their level of competence, they can experience a lot of anxiety. Neither anxiety or boredom facilitates positive growth. We're really trying to hit the sweet spot for our resident educators, the zone of proximal development. And that's just where a learner is able to accomplish a task that's given to them with a little bit of help. This is where maximal growth occurs. Our residents and our curriculum are evaluated on several levels. To gain reactionary evaluation data, we simply seek informal feedback from the residents about what they liked about our curriculum, what could be improved. Residents perform pre- and post-curriculum self-assessment as a measure of learning. To observe for changes in behavior, Dr. Johnson directly observes and provides feedback on their teaching sessions. And then to evaluate for end results, we provide residents with the student evaluation data, reports of preparedness, and pre-post quiz results. This is data from 2016 resident self-assessment. Residents reported gains in all 10 domains we assessed, but these were statistically significant. Residents were better able to author effective learning objectives. They had a greater appreciation of different teaching formats. More had a framework for feedback and an ability to give constructive feedback to their peers, and an ability to develop an evaluation tool. Next steps for the Resident-as-Educator curriculum. We hope to develop an interactive website to house this curriculum with some train-the-trainer materials. With the nearly tenfold expansion of the internship preparation course, we've recruited more residents from internal medicine, but other departments are also interested in using our curriculum. Family medicine and pediatrics are participating in it this year. To allow for high-fidelity dissemination, a centralized resource would be useful. We're also enhancing our assessment efforts. We've developed a rubric to apply to direct observation of resident teaching, and that'll be undergoing validity and reliability testing in the coming weeks to months. So as I've described, despite the volume and effectiveness of teaching, many residents don't feel prepared to do this right out of internship. Residents are interested in teaching skill development programs, and these programs are prevalent. They vary in format, though are consistently effective. And there are 2 robust local opportunities many of our residents are taking advantage of. So finally, as promised, I would like you all to leave with at least one strategy that you can implement in your practice to promote the teaching skill development of our residents. I asked this question of those 33 residents: how can faculty support your development as an educator? And this is what they said. Model short, appropriate lectures. Lead by example. Provide actionable feedback. Create more opportunities for me to teach. Offer direct observation and feedback. Formalize your expectations of our teaching role at the start of the rotation. Watch us teach and give feedback. Give feedback on my teaching. Coach the coach. Observe teaching sessions and comment. This resident notes that faculty often are not present when these teaching sessions occur, which is most often in the afternoon. And they can encourage residents who are interested in teaching to take the time to focus on their skills as educators in addition to their skills as physicians. Share their experiences in terms of what has worked well and the challenges they've encountered along the way. Our residents highlight the importance of observation and feedback, and I will echo that by holding up an exemplar from those faculty evaluations of our PG2 and 3 residents. This is a faculty comment on one of our senior residents. Teaching takes work and effort. Certainly, scheduling formal time to teach will help. For example, like we did to schedule 9 to 9:15 unless there are pressing patient care issues. Set a comfortable learning environment, use objectives, make the talk interactive, and use different formats to disseminate info. Pick a learning topic based on a patient on service. If you don't feel you can offer this specific feedback, fortunately, there are a lot of tools you can reach for to apply to direct observation of resident teaching. One I'd like to highlight specifically is the Stanford Faculty Development Program Evaluation of Clinical Teaching. This is a 26-point rubric that can be applied to direct observation of a resident teaching session. It deconstructs the tasks of effective teaching, so residents are better able to determine their relative strengths and weaknesses and focus their skill development. If you look this up after, many of you will probably recognize that some of these questions informed the evaluations our residents fill out on U.S. faculty. But what already exists? What can you do to promote the development of our residents? Make your expectations for teaching explicit at the beginning of the rotation. Observe work rounds with the sole purpose of providing feedback on a resident's teaching. Have conversations with your residents about how you assess and evaluate medical students. Schedule and attend chalk talks and provide feedback or apply one of these direct observation tools. In the outpatient setting, observe conversations when your residents are providing patient education. And more formal teaching opportunities that exist within our program that faculty are certainly welcome to attend: Advances in Medicine, M&M, Journal Club, and Morning Report. Before I conclude, I want each of you to take out your device or a pen and paper and spend just 30 seconds writing down one strategy you can take into your practice to develop the teaching skills of residents you work with. Pen and paper's fine. No stone tablets, though. So to summarize, we have high expectations of residents as teachers, and they spend a significant amount of time teaching students and co-residents. Students, residents, and departments benefit from resident teaching, and residents value that role, though they don't feel prepared to do that right out of medical school. Resident-as-Teacher curricula abound. They're varied and lead to positive outcomes, and we have 2 robust programs here at UW for our residents to take advantage of. And finally, faculty can support resident development as educators by making your expectations explicit, encouraging teaching, and providing feedback on teaching. I'd like to conclude by acknowledging these 3 individuals particularly, Dr. Sarah Johnson, Amy Zielinski, and Dr. Bennett Vogelman for their contribution to my development as an educator over the past 4 years. Dr. Page for the sincere pleasure of giving grand rounds this morning. Melissa McDonald, to whom I passed the Resident-as-Educator curriculum baton to a year ago, and she continued to run with it. My associate program directors and co-chiefs for their feedback on my talk today. And then finally, last but not least, our residents, without whom I would not have had the opportunity to develop as a teacher this year.
Thank you, Jess. That was terrific. I'll ask you to call on the audience and please repeat the question.
Dr. Skowski.
First a comment and then a question, and the comment is, thank you, residents, for all your perfect teaching that you do about medical students. Many students work in medicine and role model that you set up for students, and thank you for that. I so appreciate that as a person. And then the question is that many of our attendings, like our residents, are kind of going into teaching them. So I think we have really common parallels between attending and residents. And when we have any data on the groups teaching together, attendings and residents learning about teaching, I should say, and then using that curriculum together, I think there's common parallels.
Yeah, absolutely. So Dr. Zakowski's first comment was one of appreciation for our wonderful residents teaching and role modeling for our students. And then her question was, did I find any data on faculty and residents developing these teaching skills in parallel, experiencing the same curriculum? There's one study in particular I cited about the residents being developed as problem-based learning facilitators. Faculty were also going through that same curriculum at that time. So that was, I think, the only study that I reviewed that they were experiencing the same skill development program. But I absolutely agree that probably all of these skills could easily be incorporated into faculty development. Dr. Vogelman.
So I want to reiterate your point, and I'll make a comment afterwards on feedback. If I look at the faculty evaluations, we now in Med-Peds can put the faculty in order. We can rank them based on the evaluations that residents give them. The steepest part of the curve, differentiating the highest evaluated, lowest evaluated faculty, the other feedback questions. Residents down, being lower scores, there's certain faculty who aren't writing very much about them in Med-Peds, aren't telling them very much, giving them those large things of teach more, do more, not really doing those. So I think that point you made was really well-founded. The other thing is it's just a wonderful talk, very inspiring talk for those of us who want residents to become better, and for residents sitting in the audience listening to it. I hope you'll go ahead and publish this.
Thank you. Dr. Vogelman, his first comment was that the thing that seems to differentiate faculty educators from those that are highest performing is their skills in feedback, which I highlighted in my talk. Thank you. Any other questions or comments?
If there are no further questions, I want to thank Jess for just giving an outstanding grand rounds, and congratulations, and enjoy your weekend.